Here are 10 Puerto Rico Medical Board-style clinical vignettes focused on renal physiology, glomerular filtration, and acid-base balance, each with 4 answer choices and detailed explanations. Renal physiology clinical vignettes. 1. Glomerular filtration rate, GFR, calculation. A 25-year-old male presents for routine checkup. His serum creatinine is 1.2 milligrams per milliliters, and he weighs 70 kilograms. Using the Cockcroft-Gault equation, which of the following would decrease his GFR? A. Increased efferent arterial constriction. B. Increased afferent arterial constriction. C. Decreased plasma oncotic pressure. D. Increased cardiac output. Answer B. Increased afferent arterial constriction. Explanation. Constriction of the afferent arteriole decreases renal plasma flow, RPF, and GFR. In contrast, efferent constriction increases GFR. Potter 2. Creatinine as a GFR marker. Which of the following is most accurate about serum creatinine as a marker for GFR? A. It is freely filtered, reabsorbed, and secreted. B. It is freely filtered and not reabsorbed but slightly secreted. C. It is filtered and completely reabsorbed. D. It is filtered and completely secreted. Answer. It is freely filtered and not reabsorbed but slightly secreted. Explanation. Creatinine is used to estimate GFR because it is freely filtered and minimally secreted, slightly overestimating GFR. 3. Filtration fraction changes. A 56-year-old hypertensive man is prescribed an ACE inhibitor. How will this medication affect renal physiology? A. Decrease renal plasma flow RPF and decrease GFR. Decrease RPF and increase GFR. C. Increase RPF and decrease GFR. D. Increase RPF and increase GFR. Answer C. Increase RPF and decrease GFR. Explanation. ACE inhibitors cause efferent arteriole dilation, leading to increased RPF but decreased GFR, filtration fraction. Nat 4. Tubular transport, glucose handling. A 35-year-old woman with uncontrolled diabetes has glucosuria despite normal kidney function. Why does this occur? A. Increased GFR. B. Exceeded tubular maximum YM for glucose reabsorption. C. Increased glucose secretion. D. Increased plasma oncotic pressure. Answer B. Exceeded tubular maximum TM for glucose reabsorption. Explanation. Glucose is reabsorbed in the proximal tubule via SGLT2 transporters. When plasma glucose exceeds 200 milligrams per deciliter, glucosuria occurs. Number 5. Acid-base balance, respiratory versus metabolic acidosis. A patient with COPD has an arterial blood gas, ABG, showing pH 7.3, PCO2 60 mm, HCO read 28 µ. What is the primary acid-base disturbance? A. Metabolic acidosis. B. Respiratory acidosis. C. Metabolic alkalosis. D. Respiratory alkalosis. Answer B. Respiratory acidosis. Explanation. PCO2 and pH indicate respiratory acidosis, with renal compensation, HCO3 remains retention. Hash 6. Renal compensation in metabolic acidosis. A patient with chronic diarrhea presents pH 7.28, PCO2 34 millihers, HCO3 mon 16 molecular. How does the kidney compensate? A. Increase bicarbonate reabsorption. B. Decrease bicarbonate reabsorption. C. Decrease ammonium NH-corphamide excretion. D. Increase PCO2 retention. Answer. A. Increase bicarbonate reabsorption. Explanation. Metabolic acidosis triggers increased HCO3 main reabsorption and increased H-by excretion, and H-guamide and H2PO fluidine. Distal tubular function, aldosterone effects. Which of the following effects does aldosterone exert on the distal nephron? A. Inhibits sodium reabsorption. B. Increases potassium excretion. C. Increases hydrogen ion reabsorption. Decreases sodium reabsorption. Answer B. Increases potassium excretion. Explanation. Aldosterone increases NA-MY reabsorption, ENAC activation, K-PISE excretion, and H-by excretion via H-PISE ATPase in intercalated cells. 8. Renal handling of sodium and volume depletion. A dehydrated patient presents with low urine sodium, 10 milliricorilia. What is the main physiological reason? A. Increased ANP release. B. Increased aldosterone secretion. C. Increased NAPI secretion in proximal tubule. D. Decreased sympathetic activation. Answer. B. Increased aldosterone secretion. Explanation. Low effective circulating volume triggers aldosterone, which promotes NA-MY reabsorption and K-PISE excretion. 9. Parathyroid hormone, PTH, and phosphate handling. A 55-year-old woman with chronic kidney disease has high PTH levels and hyperphosphatemia. How does PTH normally affect phosphate excretion? A. Decreases phosphate excretion. B. Increases phosphate excretion. C. Increases phosphate reabsorption in the proximal tubule. D. Decreases phosphate secretion in the distal tubule. Answer B. Increases phosphate excretion. Explanation. PTH inhibits Na-phosphate cotransport in the proximal tubule, promoting phosphaturia. Nat 10. Renal acid-base balance, type 1 RTA. A 40-year-old woman presents with chronic metabolic acidosis, hypokalemia, and nephrolithiasis. Urine pH is persistently 5.5. What is the most likely diagnosis? A. Type 1 distal, renal tubular acidosis. B. Type 2 proximal, renal tubular acidosis. C. Type 4 renal tubular acidosis. D. Chronic respiratory acidosis. Answer. Type 1 distal renal tubular acidosis. Explanation. Type 1 RTA is caused by impaired H by secretion in the distal tubule, leading to alkaline urine, 5.5, and hypokalemia. Key takeaways for renal physiology. GFR is estimated by creatinine clearance, but overestimates true GFR due to slight secretion. Afferent constriction, GFR, efferent constriction. ACE inhibitors, GFR by dilating the efferent arteriole. Glucosuria occurs when plasma glucose 200 mg per dL, SGLT2 saturation. Respiratory acidosis, PCO2 pH, is compensated by HCO3 retention, aldosterone Na reabsorption, KT and H by excretion. PTH, phosphate excretion, and CA quad-by reabsorption. Type 1 RTA distal, impaired H by secretion, urine pH 5.5, nephrolithiasis. Would you like a